This video is for educational purposes only and is not intended as medical advice. Please consult a qualified healthcare professional before making any health-related decision.
What if the most dangerous threat to an aging heart does not arrive with a dramatic collapse, but with a whisper? A slight breathlessness while climbing familiar stairs, a heaviness in the chest that feels more like fatigue than pain, a quiet swelling of the ankles that seems like an ordinary sign of age. The human heart rarely shouts before it struggles. It signals softly, patiently, biologically, and those who learn to listen early often change the entire course of their later years. As we age, the cardiovascular system evolves. Arteries gradually lose elasticity. The heart muscle may thicken. Electrical pathways that regulate rhythm can slow or misfire. These are not immediate failures, they are gradual adaptations. But when these adaptations exceed the body's ability to compensate, early warning signs begin to surface, subtle, logical, and deeply revealing. First, unexplained fatigue is often the earliest and most overlooked signal. When the heart's pumping efficiency declines, even slightly, tissues receive less oxygen, rich blood. Muscles tire sooner. Mental clarity may feel duller. A senior once completed daily routines with ease may now feel drained by midday. This is not simply getting older. It is a biological equation. Reduced cardiac output equals reduced energy availability. The body conserves when supply diminishes. Second, shortness of breath, especially during mild exertion, deserves attention. The heart and lungs operate as partners. When the heart struggles to circulate blood effectively, pressure can build backward into the lungs. Fluid accumulation may begin at a microscopic level, long before it becomes dramatic. The result is a quiet sensation of breathlessness, particularly when walking, climbing stairs, or lying flat. Many dismiss this as deconditioning, but physiologically it may reflect early heart failure or coronary insufficiency. Third, subtle chest discomfort rather than sharp pain can signal coronary artery disease. In seniors, symptoms are often atypical. Instead of intense crushing pain, there may be pressure, tightness, or even discomfort in the jaw, neck, shoulders, or upper back. This occurs because aging nerves transmit pain differently, and reduced blood flow to heart muscle may manifest as diffuse discomfort rather than a classic presentation. The heart does not always dramatize ischemia, sometimes it negotiates quietly. Fourth, irregular heartbeat or palpitations may indicate disturbances in the heart's electrical system. Over time, structural changes in heart tissue can interfere with coordinated contractions. Conditions like atrial fibrillation become more common with age. A senior may describe a fluttering, skipping, or racing sensation. These irregular rhythms can reduce pumping efficiency and increase the risk of stroke. The electrical system of the heart, though microscopic in scale, governs life at every second. Fifth, swelling in the legs, ankles, or abdomen can reflect fluid retention linked to declining cardiac performance. When circulation slows, the kidneys interpret it as low volume and retain sodium and water. Gravity then draws excess fluid downward. What appears to be simple swelling may be the body's complex attempt to preserve blood pressure in the face of weakening pump strength. These signs are interconnected. Fatigue links to oxygen delivery, breathlessness to fluid dynamics, chest discomfort links to coronary circulation, irregular rhythm links to electrical conductivity. Swelling links to renal compensation and vascular pressure. Each symptom is not random, it is a logical extension of cardiovascular physiology. And yet, beyond the science lies something more profound. The heart is not merely a pump, it is the central rhythm of human existence. It responds to stress, emotion, diet, sleep, and movement. Decades of lifestyle quietly sculpt its structure. High blood pressure stiffens its walls. Elevated cholesterol narrows its vessels. Diabetes alters its microcirculation. Sedentary habits weaken its resilience. The early signs of heart problems are not punishments. They are reflections of cumulative biological history. In seniors, awareness becomes empowerment. Monitoring blood pressure, recognizing changes in endurance, noticing swelling, paying attention to irregular pulses, these are acts of self-respect. Early detection allows interventions that are remarkably effective. Lifestyle adjustments, medications that reduce strain, procedures that restore blood flow, rhythm management strategies that protect brain and body alike. The remarkable truth is that the heart, even in later life, retains capacity for adaptation. With appropriate care, reduced strain, improved circulation, and attentive monitoring, its function can stabilize and sometimes improve. Biology is not static, it is dynamic and responsive. When we teach seniors to recognize early cardiac signals, we are not teaching fear. We are teaching literacy in the language of the body. And the body always speaks before it fails. Unexplained fatigue in seniors is often dismissed as a simple consequence of growing older, yet biologically, it can be one of the earliest and most meaningful indicators that the heart is beginning to struggle. The heart's primary responsibility is deceptively simple: to deliver oxygen, rich blood to every tissue in the body. Oxygen is not merely air, it is cellular currency. Every muscle contraction, every nerve impulse, every thought depends on a steady supply. When the heart's pumping efficiency declines even modestly, the first system to register the deficit is overall energy metabolism. With aging, the heart muscle may stiffen, and its ability to relax and fill properly between beats can diminish. In some individuals, the force of contraction may also weaken. These subtle mechanical changes reduce cardiac output, the total volume of blood the heart circulates each minute. The reduction may not be dramatic enough to cause acute symptoms, but it can quietly limit the body's reserve capacity. Activities that once required minimal effort begin to feel disproportionately exhausting. Climbing a short flight of stairs, carrying groceries, or even prolonged conversation may provoke a sense of depletion that feels out of character. This fatigue is different from ordinary tiredness. It does not necessarily improve with rest. It can appear early in the day, long before significant activity has occurred. Some seniors describe it as heaviness in the limbs, others as mental fog or slowed thinking. The brain, like the muscles, is highly sensitive to fluctuations in oxygen delivery. Even a mild but persistent reduction in blood flow can subtly impair concentration and alertness. The physiology behind this is precise. When cardiac output falls, the body activates compensatory mechanisms. Heart rate may increase slightly. Blood vessels constrict to maintain blood pressure. Hormonal systems, including the renin-angiotensin-aldosterone pathway, are stimulated to retain fluid and preserve circulation. These adaptations are protective in the short term, but they increase cardiac workload over time. The heart must work harder to achieve the same effect, creating a cycle of strain and reduced efficiency. Importantly, this early fatigue may occur before chest pain or visible swelling develops. It may precede clear diagnostic markers on routine examinations. That is why it is so often overlooked. Seniors may attribute it to poor sleep, emotional stress, or simply slowing down. Families may normalize it as an inevitable part of aging. Yet the body is not vague in its signaling. When tissues consistently receive less oxygen than required, they reduce performance to conserve energy. Recognizing unexplained fatigue as a potential cardiac signal requires attentiveness rather than alarm. Patterns matter. A gradual decline in stamina over weeks or months, especially when paired with mild breathlessness or reduced exercise tolerance, warrants medical evaluation. Blood pressure measurement, cardiac imaging, and laboratory assessment can help determine whether the fatigue reflects early heart dysfunction or another underlying condition. The deeper lesson is that the heart does not fail abruptly in most cases. It declines through stages. Fatigue is often the first whisper of that transition, a biological reminder that circulation underlies vitality. When acknowledged early, interventions such as medication adjustment, dietary refinement, physical conditioning, and management of blood pressure or cholesterol can stabilize function and restore endurance. In this way, what appears to be simple tiredness becomes an opportunity for early detection, thoughtful care, and preservation of independence in later life. Shortness of breath during mild activity is one of the most telling early signals that the aging heart may be under strain. Breathing is so automatic, so constant, that we rarely question it until it changes. When a senior begins to notice breathlessness while performing tasks that were once effortless, walking across a room, climbing a few steps, or lying flat in bed, the body is communicating a shift in cardiovascular dynamics. This change is not random. It reflects a precise physiological relationship between the heart, the lungs, and the circulatory system. The heart and lungs function as an integrated unit. The right side of the heart sends blood to the lungs to receive oxygen, and the left side pumps that oxygen, rich blood, to the rest of the body. If the heart's pumping efficiency declines, even slightly, blood can begin to accumulate upstream. When the left ventricle cannot effectively push blood forward into systemic circulation, pressure builds backward into the pulmonary vessels. This increased pressure forces fluid from tiny blood vessels into the surrounding lung tissue. At first, the fluid shift is microscopic. There is no dramatic drowning sensation, no visible distress. But the presence of even small amounts of excess fluid interferes with oxygen exchange. Oxygen transfer in the lungs depends on delicate membranes where air meets blood. When fluid seeps into these spaces, the diffusion of oxygen becomes less efficient. The body compensates by increasing respiratory rate. A senior may feel the need to breathe more frequently or more deeply, especially during exertion. What once required minimal oxygen demand now feels disproportionate. The sensation is subtle at first, a mild awareness of breathing that was never there before. Another important dimension is exertional intolerance. When muscles work, they demand more oxygen. A healthy heart increases its output to meet that demand. An aging heart with reduced reserve cannot scale up as effectively. The mismatch between oxygen supply and muscular demand produces breathlessness and fatigue simultaneously. This is why seniors may report needing to pause more often during walks or feeling winded after routine movements. Breathlessness while lying flat, known clinically as orthopnea, offers another early clue. When a person reclines, gravity no longer pulls blood toward the lower extremities. More blood returns to the heart and lungs. If the heart struggles with volume management, this increased return can intensify pulmonary congestion. The individual may find relief by propping up with pillows or sleeping in a more upright position, often without consciously understanding the reason. Importantly, shortness of breath in seniors is not always dramatic or accompanied by chest pain. It can masquerade as deconditioning or aging. However, patterns matter. A gradual progression over weeks or months, particularly when paired with ankle swelling or unexplained fatigue, strengthens the suspicion of early heart failure or coronary insufficiency. The body's respiratory response is not merely discomfort, it is compensation. Increased breathing effort represents an attempt to maintain oxygen balance in the face of circulatory limitation. Recognizing this symptom early allows for timely evaluation, echocardiography to assess pumping function, blood tests to detect cardiac strain, and careful management of blood pressure and fluid balance. When addressed promptly, interventions can reduce congestion, improve cardiac efficiency, and restore comfortable breathing, preventing the progression from subtle breathlessness to overt respiratory distress. Subtle chest discomfort in seniors often defies the dramatic images people associate with heart disease. Instead of sharp, crushing pain, the sensation may present as pressure, tightness, fullness, or even vague unease across the chest. Sometimes it appears in unexpected locations: the jaw, the neck, the shoulders, the upper back, or even the upper abdomen. This atypical presentation is not accidental. It reflects both the biology of coronary circulation and the way aging alters sensory perception. The heart muscle depends on a constant supply of oxygen delivered through the coronary arteries. Over decades, these arteries may gradually narrow due to atherosclerosis, a process driven by cholesterol deposition, inflammation, and vascular aging. When narrowing becomes significant, blood flow during periods of increased demand may be insufficient. The heart muscle then experiences ischemia, a temporary shortage of oxygen. Ischemia does not always produce sharp pain. It produces a biochemical stress response within cardiac cells, leading to the release of metabolites that stimulate nerve endings. In younger individuals, this often results in well-localized, intense chest pain. In seniors, however, the nervous system may transmit signals differently. Aging can blunt pain perception, and conditions such as diabetes may damage peripheral nerves, further dulling classic warning sensations. As a result, ischemia may be perceived as pressure, heaviness, or discomfort rather than pain. Some describe it as a squeezing sensation or an unusual tightness that arises during exertion and eases with rest. Referred pain adds another layer of complexity. The nerves that carry sensory information from the heart pathways with nerves from the neck, jaw, shoulders, and arms. When the brain receives distress signals from these overlapping pathways, it may interpret the discomfort as originating elsewhere. This is why jaw ache during walking or shoulder tightness during emotional stress can, in some cases, reflect coronary insufficiency rather than musculoskeletal strain. The timing of discomfort offers important clues. Symptoms that emerge during physical activity, emotional stress, or exposure to cold, and subside with rest, often indicate stable angina, a predictable pattern of oxygen mismatch. If discomfort occurs at rest, becomes more frequent, or intensifies over time, it may signal unstable coronary disease, a more urgent condition requiring immediate evaluation. Importantly, seniors may minimize or rationalize these sensations. They may attribute upper back tightness to posture, jaw discomfort to dental issues, or chest heaviness to indigestion. Yet the heart does not always announce its distress loudly. It may negotiate quietly for years before a major event occurs. Recognizing patterns, duration, and triggers becomes essential. Medical evaluation can clarify the source. Electrocardiograms, stress testing, and imaging studies assess blood flow and electrical activity. Early identification of coronary narrowing allows for interventions ranging from medication that improves oxygen delivery to procedures that restore arterial patency. When subtle discomfort is acknowledged rather than dismissed, it transforms from a vague nuisance into a life-preserving signal, offering an opportunity to address coronary disease before it escalates into irreversible damage. An irregular heartbeat in later life can feel like a brief flutter, a skipped beat, or a sudden racing pulse that appears without warning. For many seniors, these sensations are intermittent and easily dismissed, yet behind that fleeting awareness lies a highly organized electrical system that governs every contraction of the heart. When this system begins to lose coordination, even subtly, the effects ripple through circulation, oxygen delivery, and overall stability. The heart's rhythm originates in a specialized cluster of cells known as the senoatrial node, often described as the body's natural pacemaker. This node generates electrical impulses that spread through the atria, prompting them to contract and push blood into the ventricles. The signal then travels through the atrioventricular node and specialized conduction fibers, triggering a synchronized ventricular contraction. This precise timing ensures efficient filling and pumping with each beat. In youth, this orchestration is remarkably consistent. With aging, however, structural and electrical remodeling can alter conduction pathways. Over time, heart tissue may develop microscopic fibrosis, small areas of scar-like change, particularly in the atrial walls. Blood pressure fluctuations, coronary artery disease, and metabolic conditions such as diabetes contribute to these alterations. As conduction pathways become less uniform, electrical impulses may travel erratically. Instead of a single, orderly signal, multiple disorganized impulses can circulate simultaneously. This disruption underlies atrial fibrillation, one of the most common arrhythmias in seniors. Atrial fibrillation does not always produce dramatic symptoms. Some individuals experience noticeable palpitations, a fluttering sensation in the chest or throat, an irregular pulse that feels chaotic rather than rhythmic. Others feel lightheadedness, mild breathlessness, or fatigue due to reduced cardiac efficiency. In atrial fibrillation, the atria quiver instead of contracting effectively. This reduces the amount of blood delivered to the ventricles and ultimately to the body. The decrease in forward flow may be modest, but over time it can attribute to exercise intolerance and weakness. More concerning is the increased risk of clot formation. When the atria do not contract properly, blood can pool in small chambers, particularly the left atrial appendage. Stagnant blood has a greater tendency to clot. If a clot dislodges and travels to the brain, it can cause a stroke. Thus, an irregular rhythm is not merely a mechanical inconvenience, it can carry systemic consequences. Other rhythm disturbances may also occur with age. Premature beats, brief episodes of supraventricular tachycardia, or conduction delays can create sensations of skipped or pounding heartbeats. While some arrhythmias are benign, persistent or symptomatic irregularity warrants evaluation. An electrocardiogram can capture rhythm patterns, and longer-term monitoring devices can detect intermittent episodes that standard testing might miss. The experience of palpitations often carries anxiety, which in turn amplify heart rate and intensify awareness. Yet beneath the emotional response lies a physiological signal worth investigating. The heart's rhythm is foundational to circulatory harmony. When that rhythm shifts unexpectedly, it reflects underlying electrical instability that may be manageable with medication, lifestyle adjustment, or targeted procedures. Recognizing irregular heartbeat as a meaningful early sign empowers seniors to seek assessment before complications emerge. preserving both cardiac efficiency and neurological safety. Swelling in the legs, ankles, or abdomen often begins so subtly that it escapes concern. A sock leaves a deeper imprint than usual. Shoes feel tighter by evening. A ring that once slipped off easily becomes snug. These small changes can reflect a significant physiological shift, the heart's reduced ability to maintain efficient forward circulation. When cardiac performance declines, even modestly, the consequences extend beyond fatigue and breathlessness. They alter the body's fluid balance in ways that are both logical and revealing. The cardiovascular system operates under principles of pressure and flow. The heart generates the force that keeps blood moving through arteries, capillaries, and veins. When the pumping strength of the heart diminishes, blood returning from the body may not move forward as effectively. This creates increased pressure in the venous system, particularly in the lower extremities where gravity already challenges upward flow. Elevated venous pressure pushes fluid out of small blood vessels into surrounding tissues, producing edema. At the same time, the kidneys play a central regulatory role. They constantly monitor blood flow and pressure. When cardiac output drops, the kidneys may interpret the reduced circulation as a state of low volume, even if total body fluid is adequate or excessive. In response, hormonal systems such as the renin-angiotensin-aldosterone pathway activate. Sodium and water are retained in an effort to preserve blood pressure and organ perfusion. While this response is protective in the short term, it increases overall fluid load. The weakened heart must then manage a larger volume, intensifying the cycle of congestion. Swelling most commonly occurs in the ankles and lower legs because gravity directs excess fluid downward. In more advanced cases, fluid can accumulate in the abdomen, a condition known as ascites, or contribute to weight gain that reflects fluid retention rather than increased body fat. The skin over swollen areas may feel tight or appear shiny. When pressed gently, it may leave a temporary indentation, a phenomenon known as pitting edema. Importantly, this symptom often develops gradually. Seniors may notice that swelling worsens toward the end of the day and improves overnight when lying flat allows fluid to redistribute. This daily fluctuation can obscure its significance. However, progressive or persistent edema suggests that the heart is struggling to keep pace with circulatory demands. Swelling rarely exists in isolation. It frequently accompanies shortness of breath, reduced exercise tolerance, or unexplained fatigue. Together, these signs form a coherent physiological narrative: declining pump efficiency, compensatory fluid retention, and rising venous pressures. Recognizing this pattern early is critical. Medical evaluation may include physical examination, blood tests that assess cardiac strain, and imaging to evaluate heart structure and function. Diuretic medications, dietary sodium reduction, and optimized management of blood pressure or coronary disease can significantly reduce fluid accumulation and improve comfort. What appears externally as simple swelling is, in truth, the visible imprint of internal hemodynamic change. The body is attempting to stabilize circulation in the face of diminished cardiac strength. When this signal is acknowledged rather than dismissed, it offers an opportunity to intervene before congestion progresses, preserving mobility, breathing comfort, and overall cardiovascular stability.